A man named Gerald came to the operating theater on a Tuesday morning. He was 67 years old, a retired school teacher from a small town in Ohio, and he had been on blood pressure medication for 11 years. 11 years of pills, 11 years of monthly refills, 11 years of being told his numbers were managed. And yet there he was, lying on a table, his heart muscle so overworked and thickened that one of his coronary arteries had begun to collapse under the pressure. His wife was in the waiting room. His daughter had driven 6 hours to be there. And all Gerald kept asking, in those final minutes before the anesthesia took hold, was one simple question. Why didn't anyone tell me what was actually causing this? That question has stayed with me. In over 3 decades of opening chests, repairing arteries, and holding beating hearts in my hands, I have seen what uncontrolled blood pressure does to the human body from the inside. Not on a scan, not in a chart, up close. And what I can tell you, without hesitation, is that most of what people over 60 are told about blood pressure is incomplete. Not wrong necessarily, but incomplete in ways that cost people their lives. Today that changes. Stay with me. Because what you are about to hear is not the standard conversation you have had in a 7-minute appointment. This is what your body has been doing without your knowledge. This is what the real drivers of high blood pressure actually are. And this is what you can start doing, beginning tonight, to change the trajectory. Here is what nobody tells you. A blood pressure pill does not fix the problem. It manages a symptom of a problem that is almost always rooted in something deeper, something that can be addressed, something that, in many cases, can be reversed. But only if you understand what is actually happening inside your arteries and why. My name is Dr. Marcus Hale. I have spent 31 years as a cardiothoracic surgeon. I have performed over 2,200 cardiac procedures. I have seen hearts that were in their 80s functioning with the vitality of a 40-year-old. And I have seen hearts that were 62 years old that looked and behaved like they had aged decades beyond their time. The difference was almost never genetics, almost never bad luck. It was information. And the people who had the right information made different choices, choices that their arteries remembered. What I am sharing with you today does not come from a pamphlet. It comes from 3 decades of watching what happens when we do not have this conversation early enough. Now let us talk about what is actually happening inside you. After 60, your cardiovascular system undergoes a series of changes that most primary care conversations simply do not account for. The walls of your arteries begin to stiffen, not dramatically overnight, but gradually, like a garden hose that has been left in the sun for years. The technical term is arterial stiffness, and it is not just a side effect of aging. It is a process that can be accelerated or slowed depending on the biological environment your body lives in every single day. Here is the clearest way I know to explain this. Imagine your arteries as a network of flexible rubber tubing. When your heart beats, it sends a wave of pressure through that tubing. If the tubing is supple, it absorbs some of that wave, dampens it, distributes the force smoothly. But when that tubing becomes rigid, every single heartbeat sends a full, undampened shock wave directly into your vessel walls, your kidneys, your brain, your eyes. That is high blood pressure. Not just a number, a wave of force hammering your most vital organs 60 times a minute of every day. Studies have found that arterial stiffness increases by approximately 16% per decade after the age of 50 in adults who do not actively counteract the process. That is not a small number. That is your arteries aging faster than the rest of you. And the causes? They are not mysterious. They are specific. They are manageable. And most of them, your doctor has almost certainly never sat down to explain. Write that down. There are 5 of them. 5 real causes of high blood pressure that go far beyond salt intake and stress, though those matter too. 5 mechanisms that, once you understand them, will change how you think about everything from what you eat for breakfast to how you sleep at night. Let us go through each one. The first is chronic low-grade inflammation. Most people hear the word inflammation and think of a swollen ankle or a sore throat, something visible, something temporary. But there is another kind of inflammation, one that produces no obvious symptoms, one that you cannot feel, and one that is almost certainly present in your body right now if you are over 60 and not actively managing it. Chronic low-grade inflammation is the smoldering biological fire that lives inside your arterial walls and quietly destroys their flexibility over years and decades. Here is what is happening mechanically. When your immune system detects something it considers a threat, whether that is oxidized cholesterol particles, blood sugar spikes, or chemical compounds from ultra-processed foods, it sends inflammatory signals to your blood vessel walls. Those walls respond by thickening slightly, by recruiting immune cells, by depositing material in an attempt to wall off the perceived threat. Over time, those deposits accumulate. The walls become harder, narrower, and your heart has to push harder to move the same volume of blood through a smaller, stiffer passage. That is how inflammation becomes high blood pressure without you ever feeling inflamed. The risk after 60 is elevated because your body's resolution mechanisms, the biological systems that switch off inflammation once a threat has passed, become less efficient with age. Research published in the journal Circulation found that elevated inflammatory markers were independently predictive of hypertension development in adults over 55, even after controlling for traditional risk factors. What does this mean for you? It means that if your doctor is only measuring your blood pressure and not measuring your inflammatory markers, specifically high-sensitivity C-reactive protein and interleukin-6, you are getting half a picture. Here is the specific fix. Ask your doctor to add high-sensitivity CRP to your next blood panel. It is inexpensive and often covered by insurance. And in the meantime, begin replacing at least one meal per day with foods that are known to reduce rather than promote inflammation. Fatty fish twice a week, olive oil instead of seed oils, berries and leafy greens daily. These are not vague wellness suggestions. They are dietary interventions with published cardiovascular evidence behind them. Starting tonight. The second real cause is something that almost no one over 60 is being counseled about, and it is happening to your kidneys. Your kidneys are not just waste filters. They are blood pressure regulators. They manage the volume of fluid in your bloodstream by controlling how much sodium and water your body retains versus excretes. When kidney function declines, even subtly, even in ways that do not yet register as kidney disease on a standard blood test, your body begins retaining more fluid. More fluid means more volume. More volume means more pressure. Here is what makes this so insidious. The standard kidney function test most doctors run measures creatinine and produces a number called eGFR, estimated glomerular filtration rate. The normal range on most lab reports starts at 60, but studies have shown that meaningful functional decline can begin in the 70s and 80s of that range. Decline that is not yet flagged as abnormal, but that is already affecting how your body handles blood pressure. The risk multiplies significantly after 60 because kidney cell regeneration slows and because decades of intermittent dehydration, common anti-inflammatory drugs like ibuprofen, and certain blood pressure medications themselves can all contribute to reduced kidney efficiency. Many of the patients I have operated on were taking medications that were working against their kidneys in ways their cardiologists and nephrologists were not coordinating around. The specific fix here is twofold. First, if you take NSAIDs regularly, even over-the-counter ones, discuss this with your doctor in the specific context of blood pressure. The relationship between NSAID use and hypertension is established and undercommunicated. Second, hydration matters more after 60 than at any earlier point in your life, and most older adults are chronically underhydrated without knowing it. The sensation of thirst becomes blunted with age. You can be significantly dehydrated and not feel thirsty. A useful practice. Drink a full glass of water before each meal, before coffee, before anything else. This single habit, practiced consistently, can reduce your blood pressure readings by measurable amounts. Stay with me, because what comes next may be the most important thing in this video. Before we get to cause number 3, I want you to understand something. Everything we have covered so far, the inflammation, the kidney function, the arterial stiffness, they are not separate problems. They are connected. They feed each other. Inflammation impairs kidney function. Impaired kidney function raises fluid volume. Elevated fluid volume stresses arterial walls. Stressed arterial walls trigger more inflammation. You are not dealing with one issue. You are dealing with a system, and the system needs to be addressed as a system. That is exactly what cause number 3 addresses. The third real cause of high blood pressure is insulin resistance and blood sugar dysregulation. You do not need to be diabetic for this to be relevant to you. In fact, the most dangerous window is the one most people are in right now, before the diagnosis. Prediabetes and early insulin resistance are estimated to affect roughly 1 in 3 American adults over 60, and the vast majority do not know it because they were never tested for it properly. Here is the mechanism. When your cells stop responding normally to insulin, your pancreas compensates by producing more of it. Elevated circulating insulin has a direct effect on your blood vessels. It causes them to retain sodium. It activates the sympathetic nervous system, and it impairs the production of nitric oxide, the compound your artery walls use to relax and expand. Less nitric oxide means stiffer, narrower arteries. Stiffer, narrower arteries mean elevated blood pressure. It is a direct mechanistic chain, not a correlation. The risk after 60 increases because decades of blood sugar fluctuations accumulate damage, and because muscle mass, which is your body's primary glucose disposal mechanism, naturally decreases with age unless actively maintained. Here is what nobody tells you. Fasting blood glucose can be completely normal, while insulin resistance is already well advanced. The right test is a fasting insulin level, or a 2-hour glucose tolerance test. Most people have never had either. The specific fix begins with 2 changes. First, restructure when you eat carbohydrates. Eating starch and sugar in isolation, as a first meal or as a late-night habit, creates the largest and most damaging blood sugar spikes. Eating protein before carbohydrates at the same meal, or pairing starches with fat and fiber, dramatically blunts the spike and the corresponding insulin response. Second, movement after meals. Not exercise, not a gym session. A 10-minute walk after eating is one of the most evidence-supported interventions in metabolic medicine for reducing post-meal glucose. 10 minutes, starting with dinner tonight. The fourth cause is one that has been studied for decades and still does not make it into most blood pressure conversations. Sleep architecture and nighttime blood pressure. Blood pressure should fall during sleep. Your body uses the nighttime hours to repair vascular damage, to allow your heart to operate at reduced load, to flush inflammatory compounds through your glymphatic system. This drop in blood pressure during sleep is so important that researchers have a specific term for people whose pressure fails to fall sufficiently. They are called non-dippers. And non-dipper status is one of the most powerful independent predictors of cardiovascular events, including heart attack and stroke, that we have. After 60, non-dipping becomes dramatically more common. Sleep quality deteriorates. Sleep apnea, which involves repeated brief interruptions of breathing that spike your sympathetic nervous system multiple times per hour, increases in prevalence. Pain and discomfort cause more nighttime waking. And the sleep medications many older adults rely on disrupt sleep architecture, even when they extend sleep duration. The specific risk here is invisible to your daytime blood pressure readings. You can have perfectly acceptable readings in the doctor's office and still be experiencing dangerous blood pressure elevations every night between 2 and 4 in the morning. If you snore, if your partner has noticed breathing pauses, if you wake unrefreshed regardless of hours slept, please ask your doctor about a sleep study. Treating obstructive sleep apnea has been shown in multiple trials to produce reductions in blood pressure comparable to adding a second medication. Write that down too. For those without apnea, the fix is sleep position and sleep timing. Sleeping on your left side reduces the mechanical load on your heart and has been associated with better overnight blood pressure profiles. And maintaining a consistent wake time, even on weekends, is one of the most powerful stabilizers of your circadian rhythm, which directly governs your hormonal blood pressure regulation cycle. The fifth cause is the one that ties everything together, and it is the one most completely absent from the standard blood pressure conversation. It is the loss of vascular nitric oxide production. Nitric oxide is not a supplement. It is not a buzzword. It is a molecule produced by the inner lining of your blood vessels, the endothelium, and its primary job is to signal your artery walls to relax and expand. When nitric oxide production is robust, your arteries are flexible, responsive, and pressure regulating. When nitric oxide production declines, your arteries lose the ability to regulate their own tone. They default to a more constricted state. Blood pressure rises not because anything has gone wrong with your heart, but because the signaling system that governs your arterial walls has been compromised. After 60, endothelial nitric oxide production declines for several reasons. The enzyme that produces it, endothelial nitric oxide synthase, becomes less active. Oxidative stress, driven by inflammation, poor sleep, and processed food, consumes nitric oxide faster than it can be made. And the dietary compounds that serve as the raw materials for nitric oxide production, dietary nitrates found in leafy greens, beets, and certain other vegetables, are often dramatically underrepresented in the diets of older adults. The specific mechanism is elegant and addressable. Your body converts dietary nitrates to nitrites and then to nitric oxide using bacteria that live on the surface of your tongue. This is not a minor detail. Antibacterial mouthwash, used daily, eliminates those bacteria and measurably reduces nitric oxide production within days. A 2019 study in the journal Free Radical Biology and Medicine demonstrated that regular use of antibacterial mouthwash was associated with a significant elevation in resting blood pressure in healthy adults. The specific fix is two-part. First, consider replacing antibacterial mouthwash with saltwater rinses or alcohol-free alternatives that do not destroy the oral microbiome. Second, increase dietary nitrate intake systematically, not through a supplement at first. Through food. Arugula is among the highest nitrate foods available. Beets and beet greens, spinach, chard, and lettuce are all high in dietary nitrates. 2 servings of these daily is a meaningful intervention, not a marginal one. It is never too late to restore nitric oxide production. The endothelium is remarkably responsive. Dietary changes can produce measurable improvements in arterial flexibility within weeks, not months, weeks. I want to tell you something from the operating room. When I am working inside someone's chest, I am looking at the cumulative record of everything that body has experienced. I can see where the inflammation has been. I can see where blood sugar spikes have left their marks on vessel walls. I can see the consequences of years of poor sleep, of chronic dehydration, of nutrient deficiency. I am reading a story that was written over decades, one habit at a time. And the hardest part of this work is not the surgery. The hardest part is the families in the waiting rooms, the spouses who drove to the hospital in the dark that morning, the adult children who flew across the country, the grandchildren who are too young to understand what is happening behind those doors. I have spoken with hundreds of those families, and the one thing I hear more often than anything else, more than grief, more than fear, is this: why didn't anyone tell us this sooner? That is what I am trying to change. Gerald made it through his surgery. He spent 4 days in cardiac recovery and 6 weeks in monitored rehabilitation. When I saw him at his 3-month follow-up, he had made every dietary change I have described to you today. His inflammatory markers had dropped significantly. His blood pressure was stable at levels better than he had seen in a decade, and he had been taken off 2 of his 4 medications under careful medical supervision. Gerald said something to me at that appointment that I have thought about many times since. He said, "I didn't need more prescriptions. I needed more information." He smiled when he said it, but there was something underneath the smile, something that looked like a grief for the years he had not had this conversation. Your heart has been working for you every single minute of every hour of every year of your life. It has never asked for a day off. It has never stopped to rest. The least it deserves is for you to understand what it actually needs. Let me give you the summary. 1. Chronic low-grade inflammation is silently stiffening your artery walls. Ask your doctor for a high-sensitivity CRP test and shift toward an anti-inflammatory diet starting tonight. 2. Kidney function decline, even subtle and undiagnosed, is causing fluid retention that drives blood pressure up. If you take NSAIDs regularly, have that specific conversation. Hydrate consistently before meals. 3. Insulin resistance and blood sugar dysregulation are impair your body's ability to produce the compounds your arteries need to stay flexible. Eat protein before carbohydrates. Walk for 10 minutes after dinner. 4. Poor sleep architecture, especially undiagnosed sleep apnea, is driving nighttime blood pressure spikes your daytime readings will never reveal. If you snore or wake unrefreshed, ask for a sleep study. Sleep on your left side. 5. Declining nitric oxide production is leaving your arterial walls without the signal they need to relax. Stop using antibacterial mouthwash daily. Add 2 servings of high nitrate greens every day. These are not difficult changes. They are specific ones, and specific is what matters. Now here is my question for you. Of these 5 causes, which one surprised you the most? Tell me in the comments below. Not just the number. Tell me why. Tell me if it connects to something you have experienced, something you have wondered about, something your own doctor has or has not discussed with you. Those conversations help other people in this community find answers they would not have found otherwise. If this video gave you something your last doctor's appointment did not, share it with someone you care about. A spouse, a sibling, a friend who is managing blood pressure and wondering if the pills are the whole story. They deserve this information too. And if you are not yet part of this community, subscribe. Because what we are building here is something different. Not alarm, not anxiety, information. The kind that changes outcomes. It is never too late to give your heart what it actually needs. One final word before you go. Everything I have shared with you today is based on published cardiovascular research and my clinical experience. But your body is specific to you. Before changing, stopping, or adding any medication, before any significant dietary intervention, please speak with your own physician. Not to get permission to care about your health, but to ensure that the changes you make are coordinated with your full medical picture. The information in this video is meant to start a better conversation with your doctor, not to replace one. Take care of yourself, starting tonight.